Namaskaram. I'm Dr. Athmaja Thottungal. I'm one of the anesthesia and pain management consultants from Kent and Canterbury Hospital in UK. I'm also a certified lifestyle medicine physician and health coach. It is such an honor and privilege to present to you and talk to you about sex and gender differences in pain and pain management on behalf of the European Society of Regional Anesthesia and Pain Therapy on the day of World Day of Regional Anesthesia and Pain Medicine. I'm going to cover the background, anatomical and physiological differences that is relevant to pain, sex, gender, and cultural bias in pain recognition and treatment, an overview of some specific pain conditions and how we should progress in future applying the inclusive, equitable strategies for pain management. Even now, women's health is considered as bikini medicine, which is only related to the reproductive side of female. In the background, if you go through the history, there is systemic institutional misogyny formed the foundation of the modern medical practice, and it is built as a very deeply ingrained structural bias within the medical research, education, and even clinical practice today. The Caucasian male is considered as a standard male model, and even in rat studies, the male rat model has been used until very recently. The female face delayed diagnosis, underdiagnosis, undertreatment, and also under research, and misinterpreted symptoms, especially regarding pain. The clinical, cultural, and the structural bias, abuse, and the multi-level barriers exist even today. And women's health is only equated to the reproductive organs till now. We need to mind the gap in pain. It is not only in pay. The sex and gender bias in pain in research and clinical practice was considered as for the global year by the IASP in 2024. We always talk, children are not small adults. The same thing applies to females as well. Women are not small men. There is a difference between sex and gender. Sex is biological sex, which is determined in utero, but the gender is a complex interplay of biological, genetic, hormonal, developmental, and societal factors. Chronic pain is a gendered epidemic. Fibromyalgia, migraine, and autoimmune pain conditions, which is up to nearly 100, affect women 3 to 9 times more than men. The biological foundation of this difference is depending upon estrogen and the testosterone hormone, which is fundamentally different in pain processing pathway in male and female brain. These hormonal differences affect everything from pain threshold to analgesic responses. The anatomical and physiological difference in the human body composition is another important factor. The muscle tissue mass, fat distribution, bone content, and also even the dynamics of the movement is different between a man and a woman. And the routes to the pain pathways are also different. If there is a peripheral tissue injury, the male brain is predominantly experiencing transmitting through the microglia, which is part of the central nervous system. But in a female, it is mainly through the T cells, which is the immune response to or the neuroimmunal response, which is transmitted into the brain. So that fundamental difference also important in controlling the pain. As I mentioned, all these physiological differences matters and affects how the drug is metabolized and also effect is obtained between man and a woman. So these neurobiological and the physiological differences is very important for the endogenous pain modulation. The pharmacokinetics and the pharmacodynamics of opioids and non-steroidal anti-inflammatory medications show a sex-related variation affecting efficacy as well as the adverse side effects. The musculoskeletal problems are a major part of the pain problems. And women have not only the skeletal structure different, even the angulation of the bones that is connected to other bones are different. The best example is the Q ankle, which leads to increased knee pain and osteoarthritis incidence in female and shoulder pathologies, especially around the perimenopausal age group. The biomechanics is different, and also the anatomical innervation of specifically the pelvic anatomy makes it the visceral efferents contributing to sex-specific pelvic and the menstrual pain pattern as well. The psychological difference is huge as well. As we know, the serotonin is an important hormone controlling the mood and anxiety. The emotional difference is mainly because men have 52% more synthesis of serotonin than women. That is one of the reasons depression, anxiety, psychological trauma, and stress is more prevalent among women, and it is strongly associated with chronic pain. The women and pain is mainly because of the high incidence in females affected by the hormonal modulation, nociception, and also the analgesics metabolism. The sex, gender, and the cultural bias is a huge part in pain recognition and treatment. The male physicians rate females' pain as less severe and more likely to be influenced by the psychological factors. This unconscious bias leads to delayed diagnosis and inadequate treatment, and many times categorized as it is all in your brain. There are various factors that affects in the diagnosis and treatment of pain, and these are all important factors that needs to be considered for the pain sensitivity threshold and also the frequency and understanding how the treatment should change. So when you consider all these factors together, the bias in the pain assessment among the public as well as the professionals, the societal pressures and the structural biases, especially considering many of the female pain that is related to pregnancy, puberty, menstruation, and menopause are all considered as normal. And also the cultural and lifestyle interventions or the influences that can affect the burden of the pain among various people from the low socioeconomic classes as well as the cultural differences that exist between the population. The hidden reality is, even though women present with the pain 2 to 3 times more frequently than men, they get less aggressive treatment and more likely to have their pain dismissed as psychological. As I already mentioned, many painful conditions throughout the female physiological changes is considered as normal. That includes the period pain, postpartum pain, labor pain, and even menopausal changes and pain related to it. Another classic example is considering the chest pain in female as atypical. Because the description of the chest pain was predominantly in a man, described by male physicians, anything that is expressed by a female is considered as atypical, even though the female population is more than men and the increased death rate from heart attack after the menopause is higher in females. Both the morbidity and mortality is higher after the menopause due to cardiovascular disease. The widespread pain syndromes are always considered as all psychological because people cannot pinpoint a specific organ that is causing the pain in women. This sex bias has led to pain management decision making and even analgesia. And this study was done in an emergency department, which has shown specifically in females, they are undertreated, less opioid and less analgesia prescription. The sexual bias in biomedical research is huge. Even though there is an opioid paradox, why women metabolizes opioid differently, requiring 30 to 40% higher doses for equivalent analgesia, they get prescribed less opioids than men. And the animal models were all animal male rats, and the human model is a 70 kg average Caucasian male. Until mid-90s, the research was not even mandatory to include women. And this is hugely underfunded, and this is affecting the huge population, female population, even though we exist more than 50%. This has led to drug dosage errors. Understanding the difference in pain processing is lacking. The evidence created is also reflecting these differences, and the mechanism of pain hypersensitivity is missing in the paradigm. It is even worse for female gender. The chronic pain is affected by the childhood experiences, especially psychological trauma in the transgender community, and this is undertreated and underestimated by the medical professionals. Especially, this is even worse if the female gender had a transgender men. Due to the diversity and having surgeries, their chronic pelvic pain is either disregarded or undertreated or underdiagnosed. So if you want to address this all in our clinical practice, we need to have a policy development including these bias and also not standardizing the protocols purely based on the WHO ladder, but it needs to be biopsychosocial and sex gender differences included. Education and the curriculum reform should be part of it as well. The physicians needs to be educated, the public needs to be educated, as well as the patients need to be educated. The research and the policy priorities which needs to be formed globally should include these and taken this as a priority for future research, especially considering all the biopsychosocial differences and people from the low-income countries as well. If you look at the overview of specific pain conditions, if we start implementing sex-specific pain protocols, it can reduce the treatment gap by nearly 40% and improve patient satisfaction and outcome. Let me give you some examples. In female life, we go through mainly 5 P's of our roller coaster physiological changes, which are puberty, pregnancy, perimenopause and menopause, pelvic pain due to various pelvic pathologies like endometriosis, and hormonal imbalances like a polycystic ovarian syndrome or any other infertility or subfertility conditions. Once a male population attains puberty, the hormonal fluctuation is diurnal until they achieve andropause. But in a female, the cyclical changes that is huge on a day-to-day basis and different hormones play a very complex orchestration in a female body. This affects pain experience changing throughout the cycle monthly as well as all these other conditions that the woman has to go through. The hormonal influences across the life course, especially the estrogen and progesterone, which modulate pain and inflammatory response, are contributing to the cyclical changes. All these changes should be considered, and the hormonal transition need to be part of the paradigm for the pain management, especially musculoskeletal and the visceral pain. Why women get more autoimmune conditions? Again, estrogen is one of the important factor, and also in a female, one of the X chromosomes goes into inactivation, and increased antibody production happens to protect the fetus, which is coming in future. The other important factor is microchimerism. It means the persistence of the fetal cells in the maternal circulation even after the delivery, which influences the autoimmune risk. And that is one of the reasons pregnancy triggers many autoimmune conditions. Puberty and adolescent pain is undertreated, and most of the time we call it as normal period pain and tell the women or the young girls are over psychologizing the pain. The menstruation related pain is a big taboo psychologically and socially among young women, which can lead to chronic pain later. Especially this is important in low resource countries. Pregnancy and peripartum pain is another one. During pregnancy, the focus shifts to the fetus rather than the mother. The mother goes to tremendous amount of physiological, anatomical, and psychological and hormonal changes, which is never considered as a part of the pain management paradigm. And the medications are limited, that is prescribed for women during pregnancy. Even the interventions are limited because of the fear of affecting the fetus, and women suffers. The perimenopause and menopause is another important aspect. Many of the perimenopausal symptoms are not even recognized by the clinicians that are related to pain, and they all blame it as psychological. There is a significant increase in the musculoskeletal joint problems, urogenital pain, and mood and sleep disturbances, which are all linked with the chronic pain. The non-hormonal options are very important, but the hormonal therapy is also an important part of the pain management in these groups. The special consideration in the low resource countries are mainly because many centers lack health professionals and limited training opportunities, specifically for sex and gender sensitive care. Majority of the people, they may depend on traditional approaches. And there are lack of national policies, and medications like opioid may be limited for availability. Multidisciplinary services are not mainly supported by the government, so they may not have enough financial resources to access these multidisciplinary services either. So in future, if we want to include inclusive, equitable strategies for pain management, what we need to do is we need to identify these current gaps in clinical guidelines and research and include those in the future researches as well as evidence creation. We also need to consider the psychological as well as the societal difference between well-developed and under-resourced countries. We should also have the representation of the gender diverse individuals, and all kind of disability needs to be part of the process as well. The recommendation should be gender specific rather than based on the male research data based recommendations. It should start with the assessment if you want to put the principles together. The assessment should become sex and gender sensitive. The pharmacological management should be tailored, including the interventions should be tailored for sex and gender context. And non-pharmacological and low-cost strategies like lifestyle medicine interventions and culturally sensitive practices that can support pain management of these patients as a part of the paradigm. All future research priorities in pain should include sex and gender as a minimum requirement for any form of research, because the evidence is lacking, and also sex-specific or the gender-specific researches, specifically for female pain conditions, should become part of the funding process as well. From a regional anesthesia point of view, we need to think about how we need to adjust our block techniques, dosing, monitoring, and the outcome of the interventions in the context of sex and gender differences as well. The future pain management should be a precision medicine rather than just one size fits all approach. Why this is important? Because we all are working very hard to prevent the chronic persistent post-surgical pain as an anesthetist and a regional anesthesia specialist and chronic pain specialist. So if you look at the predisposing factors or the risk factors, which was published by the DC Rosenberger and the team in 20 22. It's a beautiful diagram which is showing the most important factors are the both major and minor factors are patient factors, along with the pre-existing pain, how we manage the pain processing. So, regional anesthesia as a anesthesia option is not going to make a big difference, as you can see, but as an analgesia and a prevention of pain postoperatively, which is sex and gender appropriate, will make a difference. That is why we have to look at these modifiable major factors through that lens. It impacts a big time for the outcome. In this article, which was published in BMJ 2025, the prehabilitation and also rehabilitation process, which is looking at the patient-specific factors as well, makes a huge difference. If you look at the UC, which is the usual care, most of the outcomes are not that impressive. But if you add the psychology, the exercise, as well as the nutrition, which are all lifestyle factors, into the picture, the outcome becomes much, much better and more advisable. So if you want to have equality, that is not going to solve the problem for us because the same support is not going to benefit the sex and gender differences. What we need is equity. And social justice needs to be there, which is based on the education of the physicians, education of the public, and also education of the policy makers, where this inequality or inequity can be addressed. The future direction should be regarding precision and equity. The pain management should combine the sex-specific molecular target, biomarkers, and potential gene therapy with the biopsychosocial care. And all these advances like the digital health, telemedicine, and also remote interventions can extend these support to sex and gender sensitive pain management care and also even to the rural communities worldwide. So, as take home message, I will say sex and gender difference has got a huge impact on every aspect of human health. Pain management should shift from the WHO based analgesia ladder to a personalized holistic pain management. Focus should be on equity, not equality in all aspects. Lifestyle factors modification is one of the most important and highly impactful strategy that can be applied to all patients irrespective of sex, gender, or socioeconomic or geographical differences. And most importantly, as a practicing physician, I will say, please believe and validate patients' pain reports regardless of sex or gender. Avoid normalizing pain as normal pain in human physiology for females or just hormonal, or please don't say it is all in your head. Use a well structured life course lens in assessment and also making the tailor made management plan for the patients. So, as this year's plan for the ESRA as equity, access, and relief, I request all of you to take into action. We commit to evidence-based equitable pain management that recognizes and addresses sex and gender differences in pain management. Thank you very much for listening.